ఇవి జస్ట్ మన అంటే షార్ట్ కేస్ డిస్కషనే మన ఓపీడీ ప్రాక్టీస్లో యూజువల్గా ఉపయోగపడుతుంది. 65-year-old female recently presented to me with imbalance and visual disturbances. These imbalance and visual disturbances initially she noticed after waking up from the sleep. Short duration, just 5 days duration. So when she came to me, it is of just 5 to 6 days duration history. Initially she felt of, after waking up from the sleep, she felt of losing balance and tripped. And she had difficulty in fixating her eyes on the ground in front of her. Chullakpothannanu ground, nel chullakpothannanu. And she also had perception that the ground was moving even if she was standing still in primary gaze as well as if she looked into any direction. So she felt that ground was moving here and there. Okay. So it was gradually progressed within days to the extent of inability to stand. Initially there was only just losing balance while walking. It progressed over a few days, over a period of 5 to 6 days only, to the extent of inability to stand and walk without assistance. And there was no difficulty in unhooking her jacket, mixing and taking of food. There were no problems with limbs. There was no history suggestive of weakness, or there was no history suggestive of incoordination of the limbs. She was denied of any slurred speech, swallowing difficulties, numbness and weakness. She was not using any medication for any illness prior to the illness, and she was denied of any recent illness, especially flu-like illnesses, any other gastroenteritis. So there was no history suggestive of any recent illness. This is a typical short history. So tell me, what do you understand based on this history? Any one of you? So what were the primary complaints? Imbalance. Imbalance was the primary complaint. So what were the systems related with maintaining balance? Proprioception, good. Vision, vestibular function. These are the three systems. They are related with maintaining balance. One is vision, second one is proprioception, and third one is vestibular function. Vestibular function, again vestibular function, peripheral and central. Okay, so any one of these systems gets affected in this patient, either vision or proprioception or vestibular dysfunction. So in the history there are visual disturbances. Okay, so vision is affected. Then proprioception history is not suggestive of involvement of proprioception. What will be there in the history if proprioception system is involved? So
difficulty narrow spaces, walking into narrow spaces.
Not narrow spaces. Narrow spaces again suggest of vestibular dysfunction, like cerebellar involvement.
Wash basin attacks.
Wash basin attacks. So whenever she tries to close eyes while facing, while washing face, she sways. Okay. Otherwise, she feels difficulty. They feel difficulty at night times. at night times. Okay, there is no history suggest of involvement of proprioception. Then vestibular function is likely possibility. There is a severe stance and gait ataxia. She is unable to stand without support after 5 to 6 days. She is unable to walk without support after 5 to 6 days. Okay, so two systems, vision and vestibular system, get affected as per the history. But there is no decreased vision as per the history. She was telling that ground was moving. That was a symptom of visual disturbances for her. Ground was moving here and there. So vision was not decreased, but there is some visual disturbance. There are some visual disturbances. Okay, so probably mainly vestibular system gets affected in this patient as per history. Okay, then we will go for examination. Her mental status examination was normal. Visual acuity was normal. Extraocular movements. There was direction changing nystagmus. So what do you mean by direction changing nystagmus? When she looks to the right side, fast component will be to the right side. When she looks left side, fast component to the left side. What is absoclonus? Irregular dancing eye movements. Dancing eye movements. They are absoclonus. Absoclonus is not nystagmus. Okay. So direction changing nystagmus. Then hyper and hypometric saccades. Motor, sensory and reflex testing is normal. There is no dysmetria. There are no tremors. She was unable to stand with her feet together or feet keeping apart without assistance. She was unable to stand without assistance. So there was severe stance and gait ataxia in this patient. This is a CNS examination. Before CNS examination, on the general examination, I found an ulcer around the left breast, along with a lump here. Okay, there is a ulcer along with the lump. This is about examination. So what clues it was given to us? Examination. So history wise, vestibular dysfunction was there. Okay, then examination pinpoints whether it is a central part of the vestibular system or peripheral part of the vestibular system gets affected. Okay, so points in favor of central causes, points in favor of peripheral causes. Is it central or peripheral? Central. How do you say that? It is central. Okay.
And also unable to she was unable to perform.
Brahmbrooks was when she was unable to stand even with eyes open, we cannot do eyes closed. Even she is unable to stand without assistance with eyes open. So Ramberg's cannot be done in this patient. Okay. So what are the features of peripheral vestibular dysfunction? What are the features of central vestibular dysfunction? The points in favor mainly nystagmus, direction changing nystagmus. In peripheral vestibular dysfunction, unidirectional nystagmus will be there, not bidirectional. The patient has left vestibular dysfunction, fast component towards the left Even if she is to left or to right, in primary gaze or either gaze, left or right lateral gaze, same unidirectional nystagmus will be maintained in peripheral causes. So direction changing nystagmus is important point. And in peripheral causes, that means vestibular neuritis. Peripheral vestibular dysfunction means vestibular nerve involvement. Usually you won't get this much of, they will have dizziness, rotating sensation, but they don't have that much of severe stance and gait ataxia. Okay, so examination gives clues, it narrows down diagnosis towards central vestibular dysfunction. So what are the components of central? And see this patient gait once. This was actually after some treatment. This video was before that, even worse. Two members were supporting her. There is no clumsiness of limbs. This is after 3 days of course of dexamethasone. Video was taken 3 days later. It is a severe stance and gait ataxia was there. Okay. So this part we discussed. What is the localization part? Imbalance based on vision, proprioception and vestibular function. Stance and gait ataxia, direction changing nystagmus points towards central vestibular dysfunction. So component of vestibular system, the two come cerebellum and brainstem. In the brainstem, vestibular nuclei, then cerebellum. So mainly cerebellum and its connections with the vestibular nuclei and cerebral cortex and spinal cord. So cerebellum has got wide connections with the brainstem, cerebral cortex and spinal cord and thalamus also. Thalamus. Okay. Anatomically, cerebellum is divided into 3 parts. Anterior cerebellum, anterior lobe of the cerebellum, posterior lobe of the cerebellum and flocculonodular lobe. Anterior cerebellum and posterior cerebellum is divided by the primary fissure. See, this is the sagittal section of the cerebellum. Okay. And posterior lobe and flocculonodular lobe is divided by the posterior lateral fissure. So posterior lobe is the biggest part. Okay. Functionally, cerebellum is divided into 3 zones: mid zone, intermediate zone and lateral zone. So mid zone comprises of vermis and nodular part of the flocculonodular lobe. So intermediate zone, paravermis region. Lateral zone, cerebellar hemispheres. Functionally. So which part of the cerebellum gets affected in this patient? Central part of the vermis are midline cerebellar syndrome. This is a midline cerebellar syndrome. Why? So functional organization of cerebellum, when we see, it is 3 types: cerebrocerebellum, spinocerebellum and vestibulocerebellum. Okay. Cerebrocerebellum has got connections with the cerebral cortex. Okay. Spinocerebellum, cerebrocerebellum means which part of the cerebellum gets connected with the cerebral cortex? Lateral part of the cerebellum, which coordinates the limb movements usually. Okay. Spinocerebellum, vermis and paravermis region. It has got connections with spinal cord and face also. Okay, so mainly coordination of motor movements. Worm is central part of the body, that is trunk and head, and proximal limbs also. Paraworm is distal limbs, and maintenance of muscle tone and ocular movements. So remember, mainly vermis and paravermin region, trunk and face, trunk, neck and face, especially ocular movements. So when ocular movements are involved, so we can say that central part of the cerebellum gets affected along with the ataxia. Ataxia with ocular movement. So midline cerebellar syndrome, vermis and paravermin region. And vestibular cerebellum, flocculonodular lobe, mainly balance and ocular movements. So in this patient we can say that spinocerebellum and vestibular cerebellum are affected, sparing cerebellum. Okay, so this is acute midline cerebellar syndrome. Acute midline cerebellar syndrome. Then what is the pathology?
Probably
Metastasis.
paraneoplastic cerebellum.
So pathological diagnosis depends on onset and progression of the disease. Okay, this is of acute onset. This is not of sudden onset. So based on onset, we can say pathology. If it is sudden, vascular causes. Sudden means within seconds. Sudden within minutes to hours. That is acute. Minutes to hours, demyelination. Hours to days, infection or inflammation or any toxins or drugs, metabolic causes, we can suspect. Okay, so days, again, sometimes in neoplasms we can see within days presentation if there is a hemorrhage into the tumor. So neoplasms also we have to consider. Right, so this is acute onset of midline cerebellar syndrome. So is it vascular? Because it progressed over few days, vascular causes are unlikely. Usually vascular causes are of sudden onset and static, or relative improvement will be there, or deterioration, rapid deterioration will be there. Okay, is it demyelination? Demyelination chance is there, but age is not appropriate to demyelination. Demyelination means usually multiple sclerosis. Young ladies, there is chance of multiple sclerosis and demyelination. This is 65-year-old lady. Okay, so demyelination is also less likely. Then what else? Infections, inflammatory, drugs and toxins, metabolic causes are likely possibilities. So there was no history suggestive of taking drugs that induces ataxia. What are the drugs that induces ataxia? So anti-epileptic drugs. Now,
Certain antibiotics.
Now the term is changed from anti-epileptic drugs to anti-seizure medication. So anti-epileptic drugs is a obsolete term, as an obsolete term. Okay, anti-seizure medication, especially phenytoin, phenobarbital, carbamazepine, lamotrigine, any anti-seizure medication can cause, especially these drugs. Okay, and anti-neoplastic drugs sometimes, 5-fluorouracil, cytarabine, these things. Then sometimes some antibiotics like metronidazole, antiarrhythmic agents like amiodarone can cause. So there is no history suggestive of any drug intake. Infectious and post-infectious cerebellitis, usually viral cerebellitis can cause, but there is no history of any flu-like illness in this patient. Okay. So then toxic causes over. Then neoplasms. Neoplasms likely possibility if there is hemorrhage, but usually they will have some associated features like compression of the neoplasm over the surrounding structures, especially over the brainstem. Okay, so even rapidly growing tumors also, they will have few days of presentation, at least weeks of presentation rather than days of presentation. Okay, so only possibility if there is hemorrhage, but lack of other cerebellar dysfunction and brainstem dysfunction rules out neoplasms. So only leftover thing, inflammation. So inflammation, immune mediated inflammations usually, not infectious mediated inflammation. Okay, immune mediated inflammations, likely possibility either autoimmune or paraneoplastic. In this patient, on the general examination, there was a ulcer. For the past 3 months it was there. 3 months. From the January it was there. So this is 3 to 4 months history and lump. So that might be a malignant lesion. Okay. So what is the relation between presence of a malignant lesion and this acute midline cerebellar syndrome? Paraneoplastic. Usually paraneoplastic, they have subacute presentations, but sometimes even acute presentations. So paraneoplastic cerebellitis may be the likely possibility. So actually they didn't tell me about ulcer. So initially, at first glance, I thought of vestibular neuritis. Okay. In this patient, investigations done were MRI, which was negative for stroke, negative for demyelination. Okay. When I searched for other reports, and then I found that there was FNAC report. FNAC of the ulcer and FNAC of the lump suggests of duct cell carcinoma of the breast. So then I sent paraneoplastic profile this patient. It is still awaited. Okay. So what are the what are the associated cancers with the paraneoplastic cerebellitis? Especially most common is small cell lung cancer, which is common in males and smokers. Then breast cancer, gynecological cancer, and Hodgkin's lymphoma. These are the common causes of paraneoplastic cerebellitis. Common associated cancers of paraneoplastic cerebellitis. Most common antibody associated with breast cancer is anti-O antibodies. Why it was named O? Yo. That is actually, that was a person name. Patient name, first person from which antibody was isolated. Anti-O antibody, and other associated antibody, anti-Hu antibody. Hu also a person name, patient name. Okay. So I sent for paraneoplastic profile and awaiting for the report. Okay. So this is a patient of acute midline cerebellar syndrome due to paraneoplastic cerebellitis.
NMD antibodies.
but not associated with the paraneoplastic cerebellitis. Some other autoimmune encephalitis, limbic encephalitis, okay, likely possibility, NMDS. Okay, any queries in this patient? So can I ask some questions if you don't have any queries regarding ataxias? Basic exam questions. If you have any queries, you just raise it. Ataxia is one thing which bothersome for the patient and even for doctors also. They cannot sit at one, they cannot walk, they cannot stand. Okay? Okay. So what is the difference between, how many types of ataxias are there? Cerebellar ataxia and sensory ataxia and frontal ataxia also. Frontal ataxia. What are the differences between sensory ataxia and cerebellar ataxia? Gait differences. What are the differences? So white based steps are present in both sensory ataxia and cerebellar ataxia. But what is the difference?
High stepping
with eyes open.
High stepping gait is there in sensory ataxia. Lurching means as if an alcoholic walks. Lurching gait. When do you say they are white based step? What is the distance to be present
5 meters.
between 5 meters? How can a person fit? It is just 12 centimeters between two medial malleoli. To say that white based step, minimum 12 centimeters gap should be there between two medial malleoli. So white based high stepping gait in sensory ataxia, lurching in cerebellar ataxias, and Ramberg's positive in sensory ataxia, negative in cerebellar ataxias. Then reflexes are absent in sensory ataxia. They are normal, as in this patient, in cerebellar ataxia. Speech abnormality is present in cerebellar ataxia, scanning speech. Sometimes raised ICT feature in cerebellar ataxias. If they are there, headache and vomiting, papilledema, any neoplasm compressing the cerebellar system. So these are the differences between. So by looking at gait, we can say that is a cerebellar or sensory ataxia. And one more interesting point is, in sensory ataxia, patient always looks towards the floor while walking, because loss of proprioception. He is unable to perceive where he is going to keep his step. Okay, this is. So to say ataxia, what are the signs of cerebellar ataxia? Cerebellar dysfunction? Higher mental functions are normal or abnormal? Normal. Usually speech is scanning speech is there. Dysarthria, scanning speech there. Cranial nerve abnormalities? Nystagmus will be there. Abnormal sockets, pursuit movements, absoclonus sometimes. Cranial nerves. Okay? Then motor system? Hypotonia. Reflexes? Normal reflexes. Sometimes pendular knee jerk will be there. Why pendular knee jerk will be there in cerebellar dysfunction? Because of hypotonia, it moves like pendulum because of hypotonia. Then sensory testing is normal. Okay? Then cerebellar signs, typical cerebellar signs: dysmetria, dyssynergia, dysdiadokinesia, Tandem walking abnormality, finger nose test abnormalities, knee heel test abnormalities. When do you say tandem walking is abnormal? How do you say? Patient is asked to walk on a tandem line, on a straight line. Then minimum how many steps patient has to walk? At least minimum 8 steps. Okay. So if there are 2 corrections are required, 2 step corrections are required out of 8, we can say that tandem walking is impaired. 2 step corrections out of 8. Okay. What are the chronic ataxias? Chronic ataxias usually of hereditary, sometimes acquired. Hereditary again genetic. Autosomal dominant, autosomal recessive. Prototypes of autosomal dominant spinocerebellar ataxias, autosomal recessive Friedreich's ataxia. Other autosomal recessive ataxias, beta lipoproteinemia, Wilson's disease, vitamin E deficiency. Like that. Acquired causes B12 deficiency, vitamin E deficiency, hypothyroidism, multiple system atrophy, type C, cerebellar type. These are the chronic causes. Okay, stops.